Hi, I'm Lisa Brunton. I'm a researcher at the University of Manchester, and I'm presenting findings from a study investigating the implementation of a national diabetes prevention programme in England in the UK. The NHS Diabetes Prevention Programme, or NHS DPP, is an evidence-based lifestyle intervention that was launched by NHS England in 2016 and rollout has now spread out across the whole of England, with a target of making 200,000 places available annually by 2023 to people who've got raised blood glucose levels. There's 5 providers currently delivering NHS DPP across England. Local sites select the most suitable provider for their requirements through a procurement process, and NHS England directly hold the contract with the provider. Each geographical site has a local lead who's responsible for implementation across their area, and for that they receive additional financial resource to support implementation. And referral into the programme is made via general practice. A new contractual framework became operational from August 2019. This aims to improve take-up and adherence to the programme, and it also now includes a remote digital service as an alternative offer to face-to-face group delivery. A multidisciplinary team at the University of Manchester is carrying out a 4-year mixed method study to evaluate NHS DPP. So the diploma study consists of 7 work packages. They're investigating things such as access and equality, service delivery and fidelity, and outcomes and effectiveness. And work package 2 investigates implementation of NHS DPP. So understanding why the intervention can be successfully implemented in some settings but not others is a key issue for the wider uptake and sustainability of the programme, and today I'm presenting findings from work package 2. A longitudinal telephone interview study has been conducted with local leads responsible for implementing NHS DPP. We devised a purposive sampling strategy to provide sufficient case sites for detailed exploration, and we recruited a mix of sites, those in rural and urban locations and sites with different socio-economic populations, etc. For first interviews we generated a sample of 16 case sites, and for second interviews we expanded our sampling frame to 22 case sites. So a total of 20 first interviews were carried out across the 16 sampled case sites, and then a total of 24 second interviews were conducted across 19 case sites. Of these, 6 were newly sampled case sites and 13 were from the initial sample, and that's because 3 sites from the initial sample didn't respond to second interview requests. Only 4 respondents who were interviewed at time point 1 were interviewed again at second time point, and that suggests that people had changed roles in the meantime. Interviews have been analysed thematically, and we've used the constant comparative method to identify similarities and differences across interviews in order to develop the overarching themes that we present. In addition, we complemented our interview data with a survey sent out to local leads of all sites across England implementing NHS DPP to explore the variations in financial incentives and resource support that have been used to incentivise general practices to recruit patients to the programme. But today I'm going to concentrate on the interview study findings. A paper setting out the findings from first interviews and the first incentive survey have been published in BMC Health Services Research. The findings presented here move this paper on to explore how things have changed over time, and we present 5 areas to provide lessons for future practice. In first interviews, local leads felt that promoting awareness of the programme to general practice was vital for uptake, but many leads indicated that there was a lack of awareness of NHS DPP amongst the professionals recruiting patients into the programme. At second interview, site leads described greater engagement with the programme over time, but most acknowledged variation in engagement across CCGs to GP practices across their sites. Local leads were now targeting low referral or non-referring practices to raise awareness and offer support to stimulate referrals. And communication lines within GP practices were considered challenging, and leads expressed the importance of finding the right contact to speak to in general practice. At second interviews, local leads also described the importance of continuous engagement with primary care in order to maintain awareness and motivation for continued referral into the programme. The second implementation learning is around managing the provider. In first interviews, we highlighted a tension between providers and local leads due to contractual arrangements, which, as I said, meant that NHS England was the contract holder. And this led some to feeling frustrated at the lack of levers to manage provider performance. Whilst this was an issue expressed by some leads in second interviews, in general, they described good working relationships with the providers, and that was despite a relatively short time of working with them. That's because 15 out of the 19 case sites had transitioned onto the new contractual framework in August 2019, and following a procurement process, the majority had also switched to new providers at this time. So most described a smooth transition to the new contract, and this was due to having a robust transition plan in place, which included having regular meetings with all stakeholders before and during the transition process. An emphasis was also placed on the outgoing providers' willingness to share their knowledge of the site with incoming providers. Despite describing a straightforward transition, sites had encountered challenges with transition into the new framework, and the main challenge had been outgoing providers accruing long waiting lists. And this occurred due to a lack of provider capacity, a lack of communication between local leads and providers, meaning that leads weren't aware of problems until late in the day, and fluctuating levels of activity after mass mail outs received good uptake. In addition, 9 site leads compared their incoming providers more favourably to their outgoing providers, and that was due to 3 interrelating sub-themes. So, improved communication in relationship with the new provider. That included better information exchange to help local leads target populations better, improved provider capacity and resource, and incoming providers being described as more proactive than their reactive outgoing providers. At the time of first interviews, the focus was on encouraging sufficient referral volumes when rolling out the service, and to some extent this was still the case at second interviews. Indeed, sites that had moved onto the new contractual framework reported being given a significant uplift in referral targets and allocated places. However, at second interviews, although still in its early stages, there was a greater focus on targeting high needs populations, whereas when the programme started, more emphasis was placed on targeting the general population in order to meet recruitment targets. So initiatives were either being planned or underway to target high needs populations, and they were carrying out outreach work to increase uptake amongst the black and minority ethnic populations and working age populations, for example. Receiving monthly data from providers in a user-friendly format helped them to target local population needs, and some reported working with the recently created primary care networks to identify high needs populations. In first interviews, recruitment processes were considered to affect the quality of referrals and the subsequent uptake to the programme. And at second interviews, there was an emphasis on getting what they called business as usual. And this meant wanting to move away from conducting case-finding searches and mass mail shots to referrals being made during routine consultations or health checks. But sites still had a long way to go before enough referrals could be gained from these referral processes. At second interviews, some site leads were exploring the option also to widen referrals out to other routes, such as to secondary care. Data from first interviews and the incentive survey highlighted how the money allocated for the implementation of NHS DPP was being used in different ways to support GP practices to recruit patients, but the majority of sites were using financial incentives. There were 3 main ones being used, and they're listed on the slide. At the second interview stage, some sites were still using a variety of financial incentives, but a number of local leads described the desire to stop financial incentives, and in some cases they were no longer being used. And the main reason for this was because leads were unclear regarding the benefits gained from providing financial incentives. Some local leads felt it was more effective to provide resource support. So, for example, they talked about employing facilitation officers to conduct case-finding searches in general practice. The final implementation lesson surrounds sharing learning. At first interview, the importance of sharing knowledge was recognised, but the forum for sharing learning wasn't always there. However, learning from other sites was seen as important, especially later sites learning from sites that had implemented NHS DPP earlier, to learn from the challenges and successes that they'd encountered. At second interviews, this issue was discussed less and there was more emphasis on learning from their own previous experiences. Learning was mainly confined to sharing knowledge with neighbouring sites, and in general, there still appeared to be lack of learning opportunities nationally. Some leads reported being willing to share their learnings, but not being provided with the opportunity to do so. So to move on to the discussion, NHS England implemented a national diabetes prevention programme, and we've conducted interviews with site leads to explore the challenges around implementation with the aim of providing lessons for future practice. The implications of our research identify lessons for future implementers. There's a need to prioritise awareness of the programme to get clinicians to engage and sustain engagement in order to continue successful referrals onto the programme. There's also a need to define clear responsibilities for stakeholders before and throughout implementation. And the need for a robust transition plan, which includes regular meetings and a good relationship between the outgoing and incoming provider, are all important for a smooth transition. And finally, there's a need to provide mechanisms to share learning across the country. Thank you for listening.